Thank you for joining us in this question and answer about epilepsy. My name is Alfredo Quinones-Hinojosa. I'm the chair of neurosurgery here at the Mayo Clinic in Florida, and I am right next to my dear friend, colleague, and mentor, Dr. Anthony Ritaccio, who is a brilliant epileptologist as well as a professor of neurology and a joint appointment in neurosurgery in our department. So we get to do a lot of work together. It's always an honor and a pleasure to be together in these occasions and to spend time in the operating room. So what we'll do today, we're going to answer a few questions from the Mayo Clinic network that have been sent to us. And then after that, we'll leave a few minutes at the end to answer some live questions that are coming through our direct feed, live feed in our Mayo Clinic. So thank you very much for joining us. I guess we're going to start by discussing some questions we often hear, and then we'll take some of these other questions. One of the things about our membership with the Mayo Clinic Connect is that it allows us to see what other people are thinking around our network, which is large and very, very extensive. So one of the questions, Dr. Ritaccio, that people often ask is, what percentage of epilepsy surgery gives 100% seizure control without any side effects on the long term?
Well, that's an easy question to answer statistically, but I have to go backwards for a moment. Epilepsy is the most common neurologic syndrome across all ages, and it affects 3 million adults and about roughly 470,000 children currently in the U.S. It is not one illness, but many illnesses with many different causes. The common expression is seizures, of course. And we expect maybe 30% of those people to be refractory to medicines, and despite trying 2 or 3 different medicines, seizures will continue. Those people are candidates for epilepsy surgery. It requires an extensive multidisciplinary workup, which you and I are very familiar, and many in the audience. When we do epilepsy surgery to obviously appropriate candidates, we expect seizure-free rates to be on the order of 70%, not 100%. But drug-resistant epilepsy patients may expect seizure freedom rates in the order of 2 or 3%. So 70% is as good as our current technology and surgical expertise can give, but it far exceeds the benefits of medicines for drug-resistant epilepsy.
And I would just like to piggyback on the issue of the side effects. Of course, Dr. Ritaccio and myself, in our group of epileptologists as well as epilepsy surgeons, we work together to try to make sure that the surgery is safe. Many times we go together and we see these areas that are epileptogenic that are right next to areas of speech or motor function or ability to understand or produce sounds, and we have to map the brain, and that's exactly what we do together. So the more experience a team has in epilepsy, both from the medical side and the surgical side, the higher the chances are that those patients are going to have a better outcome. Thank you. That was a great question. I'm going to piggyback on this, Dr. Ritaccio, and ask you the question of, is there anything right now currently available in the pipeline similar to responsive neurostimulation for what is known as tonic-clonic seizures that will stop those seizures before they even get going? So a vision into the present and potentially the future.
Sure. Well, we do have, as was mentioned in the question, responsive neurostimulation refers to a device called NeuroPace, which is in current usage, certainly by us and other epilepsy centers. It's a device which is implanted in the brain and can be trained to recognize seizures at their onset and then try to electrically interfere with them, and very often to great effectiveness. We understand that in the future, it's certainly probable that drugs will go by the wayside, and I think we'll be fighting fire with fire, so to speak. That is to say, a seizure is a sudden electrical discharge that influences behavior and consciousness, and that we'll be using subtle forms of electrical stimulation to interfere with or abort seizures. So currently, for example, The most recent addition, at least within the context of FDA-approved devices, is the use of deep brain stimulation, which is a different type of implant, very similar to the one that's used to treat Parkinson's disease. And that has the ability to abort and prevent seizures. And then in the future, there are many devices in the pipeline. The one which we can speak of is a Mayo-centric device, one that was developed in Mayo Rochester, and we've implanted here as well in several patients. And that's something called chronic subthreshold cortical stimulation, which is another type of implantable device that gives the brain, in a particular location where seizures begin, a continuous electrical discharge that acts as a field of interference so that seizures cannot initiate. And I think that's where the future is headed.
And I was just thinking about the times that Dr. Ritaccio and myself and our team have been in the operating room, and suddenly we stimulate and a patient starts having a seizure, and Dr. Ritaccio will sometimes ask me, give him another stimuli right there and then, and you'll be surprised how many times we can actually break that seizure by just doing that. Basically, as he said, fighting fire with fire. Similar, Dr. Ritaccio, is that what are the similar? People are, familiar with pacemakers in the heart, with all the devices that are implanted in the heart. So, is there a similarity into what the future is for us as we understand more about brain function for implants?
Well, I think the sky is the limit. As we understand more about the electrical behavior of seizures, we'll find better devices to electrically inhibit seizures. It doesn't just reside only in electricity. As you know from all your years or decades of training as a neurosurgeon, one of the most common ways to treat a seizure that should happen in the operating room is the use of cold water. Just reducing brain temperature rapidly interferes with seizures. So there are devices that are currently in experimental use and haven't transferred to human use yet that will selectively cool a part of the brain to inhibit a seizure, with devices that are very similar to the devices that are embedded in all our laptops so that our microprocessors don't get too hot.
Amazing, amazing future. Please, if you are just joining, don't forget that we have this live question and answer about epilepsy, and please make sure to leave your questions in the comment section. I'm going to piggyback into this question about the percentage, because it's related to what you mentioned, the percentage of epilepsy surgery that gives 100% seizure control without side effects. I think that that's something that a lot of patients, because they're afraid of brain surgery,
right.
And I think that probably this is the cost-benefit analysis. How bad is the potential side effects of brain surgery versus the potential side effects of having epilepsy for a long time when you may consider that patient a candidate for brain surgery?
Well, we all have a great deal of, all of us that do this work have a great deal of humility, and we don't always know everything. But I think that we clearly understand, and we have in our multifactorial assessments, imaging, and electrical recordings, and other technologies before we operate, we have the ability to understand who's at risk for deficits and what those risks would be, so much so that if we really feel that someone's epilepsy onset area is an area that they can't stand to lose, then we won't recommend surgery at all. But if we understand that we can avoid these deficits, then we certainly advocate for it. And I always tell my patients that epilepsy isn't one disease, and we don't paint this disease with a roller. Mm-hmm. And that I use these simple analogies. But if you go to the emergency room with abdominal pain, and if it turns out that you have an infection, then maybe you get an antibiotic. But if you have appendicitis, then the appropriate treatment is to remove the appendix. And it really has to be noted that there are some forms of epilepsy where there is a small structural abnormality causing the patient's epilepsy. There is a pearl in the oyster. It may be an abnormality that we're born with. It may be an abnormality that was acquired after trauma, and that the only cure comes with removing that small lesion. Wouldn't you agree?
I would say that, especially in the field that we have been developing more recently here at the Mayo Clinic in Florida, which is we coin as a team as oncoepilepsy, we go in and we sometimes can take a tumor out successfully, and with new devices that we have invented here, actually, we can detect parts of the brain that may actually be epileptogenic, that if you only remove the tumor, we are at risk of potentially leaving that other part of the brain that is going to continue to give the patient epilepsy. So now we aim at curing not just the tumor on a patient, but potentially that part of the brain that will give the patient epilepsy. And by default, our objective is to give those patients a better quality of life, so that way we can control two things at once. But I think that that's obviously one of the goals that we have. And of course, the side effects always with any surgery is loss of function. This is why we have specialized tremendously in keeping a lot of our patients in the operating room awake to not only understand brain function, but to really get behind the etiology and resection of areas that will leave our patients with a good quality of life. So, to continue some of these questions, Dr. Ritaccio, one of the questions is, why do so many physicians do surgery if two medications are unsuccessful in controlling seizures? And then this one of our colleagues asked, I know many people who have total or near total seizure control on 3, 4, and sometimes up to 5 medications. This is really up the expertise that you have developed over the years.
Well, all I can say generally is whatever controls someone's seizures, good for them, because it's an exploration, and it's an exploration that often takes years. But we know a lot. We know a lot through extensive research in the lives of patients with epilepsy, not over years, but over multiple decades. And it's very clear that, so clear that there's an international definition of drug-resistant epilepsy. It's universally agreed upon, and it's almost always correct. And that is that if you've had repetitive seizures in your life for over 2 years, and you've tried 2 medicines to their highest tolerated dose, it is extremely unlikely that a 3rd, 4th, or 5th medicine will make you seizure-free. We would just rather see people who have a 70% chance or an 80% chance of seizure freedom with a simple epilepsy surgery, rather than see them 20 years into trying medicine 5, 6, and 17, when we know that after 2 or 3 medicine tries, the likelihood of seizure freedom is in the order of 1 to 2%. So, so we would really like to identify candidates, and there really is an international agreement that surgical candidacy should be assessed within 3 years or 2 or 3 years of this diagnosis. People should get what is required.
And I'm going to piggyback on that question, because I think Dr. Ritaccio mentioned something very important. The longer you have epilepsy that is not well controlled, the more challenging it keeps getting to get that epilepsy control. And the second one is the fact that, of course, everybody has the right and the prerogative of trying more than 2 medications, as Dr. Ritaccio mentioned, the higher tolerated dose. And if they want to try more, I think that these are discussions that you must have with your epileptologist. In this case, Dr. Ritaccio sits there. I've seen him sitting with patients discussing the pros and cons. And I think having that discussion back and forth, is very important. And of course, you have to realize that sometimes once you go beyond 2, 3 medications, the side effects sometimes they can be absolutely devastating for the quality of life of a patient. So that's where we put the cost-benefit analysis.
I would just add one very important point about, I think, polytherapy, the use of more than one medicine. If someone is on 3 medicines with lack of control, and then a 4th medicine is added, and there's a dramatic benefit, it doesn't mean that all 4 medicines are required. It means that the 4th medicine is really the ball carrier, and the first 3 are bystanders. It doesn't necessarily mean that there's some magic cocktail there. So, and it's never been proven that more than 2 drugs are necessary to control seizures.
Very, very good question. Well, this next question is really something that we have a tremendous expertise here at the Mayo Clinic, and that is, when you have a patient that has a question of epilepsy, the electroencephalogram routine is normal. The question is, how do you then decide when to do a sleep-deprived or an ambulatory electroencephalogram for patients?
Well, that is, one of the most fundamental questions in the field of epileptology. EEG has existed since the 1930s. It certainly is a very easy test to do, and it's non-invasive, and it takes about 40 minutes to an hour, and it's just passive listening to brain waves. However, we know that in at least 50% of people, those listening devices where we passively listen to your brain waves for, again, the better part of 40 minutes to an hour, it will be normal in 50% of people who really have epilepsy. That is to say, we're looking for some irritability which may be present this hour, but may be absent the following hour. So there's, as we say, there's an ascertainment bias or a sampling error. If we don't see that irritability, it doesn't mean that the seizure disorder doesn't exist. But beyond that, there are dozens and dozens of different seizure syndromes, some acquired, some inherited. There are over 24 medicines. There are some seizure medicines that are specific for this particular epilepsy syndrome. There are some seizure medicines that will make certain epilepsy syndromes worse. So we like to understand which syndrome you have. That can only be discerned through one and only one mechanism, actually recording the patient's typical seizure. That usually involves continuous monitoring over days and nights. Sometimes in an inpatient setting, we'll actually remove the patient's seizure medicines on purpose to provoke and bear witness to the seizure. So in the spell business, you have to bear witness sometimes, especially if you're making a surgical plan or you're trying to counsel a patient as to whether a surgery is even a useful approach with a high cure rate. You have to record and make a map of where that seizure comes from.
I would say that the other thing that is very important, I am, as a practicing neurosurgeon here at the Mayo Clinic, and sometimes I have patients that we need to get ambulatory EEGs. It's very important. I am very, very lucky to have an extraordinary team of epileptologists like Dr. Ritaccio. It is very important to consider that ideally, in the perfect situation, it should be your epileptologist for this particular team that reads even those ambulatory EEGs, because sometimes, unfortunately, in some places, some of those EEGs are outsourced to people outside of their sort of area that have never met these potential patients. And I think that's something very, very important to consider if you are attending or if you are going to visit a center of excellence for epilepsy. And that's exactly what we do right here. So I have a very specific question right here, Dr. Ritaccio, and I wanted to ask you because I think it's one of the questions that is coming through the live audience right now. This person asks, I want to know about myoclonic epilepsy. Is it dangerous in the long term? And is vagus nerve stimulation surgery useful to some extent, knowing that the person has been already dealing with this for 9 years and is a young patient, 23 years of age?
Well, again, I don't know that we can really accurately or specifically answer that question. A myoclonic seizure is a sudden seizure. Typically, clinically, the extent of the seizure is less than a second. It involves a certain involuntary jerk of a muscle group, typically in upper or lower limbs or trunk, where there's a sudden seizure discharge that makes the muscles jerk. There are many different forms of myoclonic epilepsy. Some forms are extremely well controlled with medications. In fact, over 95% seizure freedom with certain medicines for some forms of myoclonic epilepsy. And there's some forms of myoclonic epilepsy that require a very, very deep approach and investigation. So again, it's very syndrome specific.
Correct. These are difficult challenges, situations, of course, but what I would encourage anybody who's battling with anything with epilepsy, please visit, get the correct information, visit centers of excellence like what we have at the Mayo Clinic, where they're multidisciplinary, neurologists, neurosurgeons, neuroradiologists, neurocritical care. A lot of people get together to discuss. Here, actually, every Friday morning we get together. Every Monday morning we get together. We discuss extraordinarily complex cases, and we have a room with about 20, 25 people, and we're asking each other these very complex questions. I have another question for you that is coming from a Mayo Clinic Connect member. He says, my husband has had 6 seizures after a stroke at age 74. He's now 77 and takes Keppra, lamotrigine, and Vimpat. His cognition, mood, gait, balance, and ability to function are now severely compromised. Could his doctors at least do a level or look at the combination as being in this state is not sustainable for him? So what can be done in such a situation? So clearly the patient had a stroke, something changed in their brain, is probably in an eloquent part of the brain, and now the patient is suffering from epilepsy. Sounds to me that several medications are given, and we know a lot of people do suffer a stroke. So how do we deal with that, Dr. Ritaccio?
Well, that defines pretty much 90% of the existence of an epileptologist. That is to say, the majority of our patients have seen 3 or 4 neurologists over years or over decades, and they failed multiple medicines. Failing a medicine, as you've already, I think, implied, there's 2 aspects to that. One is having seizures despite medications, and the other is having a side effect that you do not wish to tolerate. So that in this case, obviously, we have a very general problem. Poor control and side effects that are not tolerable on a multi-drug regimen. Again, a common problem, and a problem that takes some time to understand. As the questioner correctly suggests, it might involve blood work, understanding these drugs, the blood levels that reflect what is happening in the brain, understanding how these drugs influence each other in good ways and sometimes in bad ways, and then proposing a plan to simplify the regimen, make it less intoxicating for the patient, which is a synonym for toxic, or in the case of someone with a stroke who already has disabilities, sometimes people with strokes, because of the scar and the deficit of the stroke, they're much more sensitive to the side effects of these medications. So it just requires finesse, time, testing, and expert manipulation, and usually people can have better control and less toxicity. But yes, as the questioner implies, it requires interest and testing and a plan. I always tell people epilepsy is a chronic disease. If you go to a physician and they give you a prescription and say, here, take this twice a day, that's part of the solution, but you should be hearing a short-term solution, an intermediate-term solution, and a long-term solution, because it tends to be a lifespan disease.
And I would say to that as well that, as Dr. Ritaccio mentioned at the beginning, millions, more than 3 million people are affected by epilepsy. Those are the ones that we know. It's probably the numbers larger than that, but we have a lot of patients that we haven't been able to diagnose because they don't recognize their symptoms as epilepsy, symptoms. But if you think that you have epilepsy, consult, of course, with your primary care physician. You do have an ability to obtain a potential opinion by a neurologist, and eventually, if this turns out to be something complex, having an epileptologist like Dr. Ritaccio, having a brain surgeon like myself who does epilepsy would be of benefit to you. And talking about this next question is an important question. This one has to do with Epidiolex. So I'm going to ask you to tell our audience what is Epidiolex, and also why hasn't been the epilepsy cure-all as once thought. Can you talk about the actual success rate of this?
Sure. It is a controversial subject. It's the subject, of course, of medical marijuana. So Epidiolex is currently an FDA-approved substance that's derived from that plant, and has been tested, although there's a lot much more testing that needs to be done. So we have some early evidence of effectiveness. When it was applied across many different syndromes and across all age groups, and at least in the largest study to date, which I think is roughly around 140 patients that were attempted that were drug resistant, there were reductions in seizures of about 30%, meaning that if someone had a severe case of drug-resistant epilepsy and was being visited by 10 seizures a month, then perhaps they had 6 or 7 a month after adding this substance to their regimen. So that's an improvement, and it's certainly some proof of effectiveness, but it's not the seizure freedom drug, and we don't have a seizure freedom drug for drug-resistant patients, and so much more work needs to be done. But right now, the ability to reduce seizures by 30% is a common property of all FDA-approved drugs, including Epidiolex. So happy to support its use in a drug-resistant patient. But again, I would apply the general rules across the board. If you've had this for more than several years and you've failed 2 or 3 or 4 medicines, whichever medicines they are, including Epidiolex, then you should understand whether or not there's a different way to control your seizures.
And I would say that the challenge that we have right now with epilepsy, especially with those epilepsy cases that are quite complex and really they have had all kinds of medications and potentially surgery, they still, affecting the patient's quality of life, is the fact that we just don't understand the etiology. We don't understand how the brain's plasticity has allowed to these potential new circuits to build and have the ability to synchronize their neurons from firing from time to time. And I think that that's going to be part of our future, and that's something that Dr. Ritaccio has done a fair amount of research on that subject matter. I'm going to follow with another question. Phenobarbital. You used it. We used it for more than 100 years. Is more often in the United States. It's helped a lot of people. In this particular person asking, including myself, the person says, so why not, use it more often? What are the side effects? What are the pros and cons?
Well, if someone's been on a low dose of phenobarbital for years or decades and they're seizure-free, then obviously I support its use. I don't think you'll find too many physicians, neurologists, or epileptologists initiating that drug in a new epilepsy patient for a number of reasons. First of all, it's a drug that sedates patients, has a significant side effect risk of depression, can slow down cognition so that in children it can cause a type of drug-induced learning disability in the school-aged child. So pediatric neurologists will always stay away from its use. It's a drug that excites the liver to be actually overactive, and that will lead the liver to essentially more rapidly eliminate other important medicines. For example, your cholesterol medicine at a standard dosage may not work because you're eliminating it twice as fast. It'll eliminate vitamin D twice as fast, and so we see people that have chronically been managed on a phenobarbital for decades evolving into osteopenia and osteoporosis or bone thinning, even men before the age of 30. So it's not that it can't work, it's just that we have probably at least a dozen medicines that are simple, have no organ-specific side effects, do not sedate, require no blood work, so we would much rather turn to them.
And I would say this is exactly why having an expert epileptologist like Dr. Ritaccio at an expert place like the Mayo Clinic is important for patients to get that kind of opinion, that kind of knowledge, and that kind of expertise. One specific question right here, Dr. Ritaccio, and this is about a listener. He said, I had a seizure for the first time after having a colonoscopy. I have terrible reactions to anesthesia, and I am worried about having another seizure. Is this common? We've seen it, of course, with our own patients in the operating room when we do surgery for something else. Just last week, I was doing surgery for a spine situation, and I had a patient that woke up with an epilepsy. What are your thoughts about this?
Well, actually, I would use this as a point to bring up the general concerns about how we make this diagnosis to begin with. Having a single seizure is not epilepsy. It doesn't mean you're destined to have 2 or repetitive seizures in your life. The definition of epilepsy essentially rests on repetition. It's the ability to have a second or third seizure in the future, or if somebody has a single seizure and they're concerned, then they need a very extensive and responsible workup to understand if there's what we call a biomarker for seizures. In other words, I had a seizure after colonoscopy, but if we do an image and we find an abnormal collection of blood vessels in the brain that's known to provoke seizures, then that's a biomarker, and that might mean a high potential for repetition. If we do a workup, if we do an MRI, if we do more sophisticated scanning, and we find that there's no risk factor for seizures that we can identify, then we will most likely opt not to medicate a single seizure. So it involves not just using that seizure as a takeoff point to diagnose a chronic disease for life, but rather to press the pause button and fully evolve a very complex workup to identify whether or not there are risk factors in the future.
We have time for just a couple more questions, and this is one from our listeners. regards to hemispherectomy, because these are, of course, complex in nature, a few centers in the world can do them. Does a hemispherectomy ever accomplish 100% seizure control without changing the seizures or causing other side effects? That's a tough one, of course, to answer. I have experience with hemispherectomies, and first of all, they're never 100, nothing is ever 100%. Second of all, there are side effects related to the surgery itself, and then, of course, the possibility is still not able to control the seizures. What is your experience, Dr. Ritaccio, with this procedure?
Well, that's probably the most specific question that's been asked over this time period. Hemispherectomy is as you know, and as you perform this type of surgery, it's a surgery that's usually performed in children, and it's usually performed, or exclusively within the context of epilepsy, performed in patients that have a unique type of syndrome that we call Rasmussen's encephalitis, in which case the surgery can be literally life-saving in almost all cases, and in majority of cases, including, I would say, greater than 95% of cases, will halt the disease and save the life of the child and greatly ameliorate or eliminate the patient's epilepsy. And yes, taking away nearly a half of someone's brain sounds like a radical thing to do. But when this is done, and particularly when it's done under the age of 7, as you know, there's incredible accommodation, and the brain develops all sorts of strategies. So this is a heroic epilepsy surgery. We know when it's indicated. We know when it needs to be performed. And when we do it, and for the right reasons, the patient and the patient's family is always happy we did.
Amazing, amazing work. One question, what options are there when you're not a surgery candidate and a brain pacemaker isn't controlling the number of seizures that a patient is having? So now we're talking about, of course, potentially medication was maximized. You're not, you are not a surgical candidate. Probably you don't have a lesion. There's nothing that is pointing. And pacemaker is no longer working well. What other things can a patient try?
Well, again, that's also a common thing we field almost on a multiple weekly basis in the office of an epilepsy subspecialist. That's why I think patients need to be, at least patients within the context of this description, need to see an epilepsy subspecialist. We can lead you to alternative implant therapies like the experimental therapy that Mayo is now conducting in Rochester and here in Florida. Alternatively, we have experimental drug trials for the drug of the future so that the patient may be a candidate for an alternative drug trial for a drug that eventually may be more promising because we have several drugs on trial here at any time.
I'm going to ask you, this is a two-part. One, to define SUDEP, S-U-D-E-P, and number two, why is it that more doctors do not talk about this openly with their patients?
Well, that's, again, a controversial question and topic. SUDEP refers to sudden unexpected death in epilepsy. Again, epilepsy is not a diagnosis. I tell my patients, using the word epilepsy is like using the word cancer. There's skin cancer, there's brain cancer, there's thyroid cancer. Some cancers are treatable, some cancers are resistant to therapy. Some cancers do better with surgery, some cancers do better with drug therapy. But in general, we understand that if you have drug-resistant epilepsy, and if convulsive seizures are part of your repertoire, in other words, you experience convulsive seizures that are difficult to control, and if those convulsive seizures occur at night, there is a risk of mortality, either due to cessation of breathing or cessation of heart rate. It's extremely low. It's in the order of 1 in 1,000 to 1 in 10,000. It's very hard to calculate. The point is, engage. Engage with your neurologist, engage with your epileptologist, eliminate convulsions, reduce them, change your medicines. It's not a stumbling block, and even though that's a morbid thing to talk about, we do feel it's important to discuss that with patients. But it shouldn't be a deal breaker. And again, I usually tell my patients to think about driving, Dr. Quinones. Within the context of the life, let's say, driving from the age of 16 to whenever you give up your license, there's a 1 out of 4 chance of being involved in a 1 or 2 car accident that could put you at risk, and yet we drive, we engage. So having this risk, which we have to openly speak about, should just stimulate us to do better.
This is wonderful. What a great pleasure to be here with you, Tony, Dr. Ritaccio. And this is all the time we have for you today. Thank you for watching us, and thank you for joining us. And please do not hesitate to reach out at the Mayo Clinic for any further questions you may have. Have a great day.
Thank you.
Thank you for joining us today for this video Q&A. To find out more about future broadcasts, as well as share your experiences and find support from people like you, visit Mayo Clinic Connect at connect.mayoclinic.org. To request an appointment, visit mayoclinic.org.